All right, so thanks everybody who's joining us here today and those who are listening to the recording. Like I said, my name is Hugh Quinn. I am a clinical pharmacy specialist. I work at WVU Medicine in the Endocrinology Clinic up in Suncrest Town Center here in Morgantown. Just to start things off, I have no financial disclosures to make for this presentation. Any use of brand names is for identification purposes only. And for today's presentation, I've been asked to talk about classes of medication used to treat primarily type 2 diabetes. So we'll go through those with brief overviews, focusing mostly on oral and non-insulin injectable medications. We'll talk about the pros and the cons of different classes and even within some specific agents within those classes, and talk about some hopefully useful clinical pearls as we go. And we'll sort of discuss how to identify those that can benefit from certain therapeutic interventions. So I'd just like to start off with a patient case just to keep in mind. We'll sort of work through this as we go here through the presentation. So we have a 52-year-old Caucasian female who presents to clinic. She denies any vision changes, weight loss, or loss of sensation in her extremities, no increased frequency of urination or thirst. Past medical history is significant for obesity, hypertension, hyperlipidemia, and type 2 diabetes, for which she was diagnosed 6 months ago. Current medications include lisinopril, atorvastatin, and metformin, 1,000 milligrams twice a day. And here's most recent current lab results for you, which are all fasting. There's A1C there, LDL, triglycerides, EGFR, BMI, blood pressure, and albumin creatinine ratio. So we'll sort of work through this patient as we go and just use it to discuss the different medication classes here. As always with diabetes, though, we do like to stress that the first line treatment option should always be non-pharmacological treatment. A lot of patients can have success with this. Some diabetic patients are managed with diet and lifestyle only. It's not common, but it is possible for some people. And even moderate improvements in lifestyle and diet can have significant outcomes. So even just a 5% weight loss can be pretty significant for a lot of people. So we like to stress things like that on physical activity, smoking cessation to reduce cardiovascular risk, and also restricting the alcohol consumption. One thing with diabetes treatment, whenever we're deciding how to treat patients, we really need to individualize the goals of therapy. So there's no one real black and white cutoff when it comes to diabetes management. A1C goals and other goals can be very different from patient to patient. So the first thing that we usually like to do when we start off is figure out what the goals of therapy are for this individual patient, and then we can sort of assess what medications may be appropriate or not appropriate going forward. So this is from the ADA, most recent, the American Diabetes Association guidelines. And I want to put up this here to highlight, most recently in their newest update this year, they changed the wording of the first line therapy. So now it no longer says first line therapy is lifestyle and metformin. It goes a little bit further and says that first line therapy depends on comorbidities and patient-centered treatment factors, including cost, access, considerations, and management needs. And it generally includes metformin and lifestyle modifications. So that kind of opens up the door for us to use things like GLP-1 receptor agonists and SGLT2 inhibitors as first line therapy. So that was something we were pretty happy that the guidelines had made a change for, and really opens up the door for us to get aggressive with our first line therapies. And then you see, as we go here, we'll work through this algorithm a little bit, but the next step is to assess the patient for comorbidities and select a medication that can help reduce risks of things like ASCVD, heart failure, hospitalizations, or progression of chronic kidney disease. And we'll talk about different agents and how they work to do that as we proceed here. Another thing that I want to highlight with these guidelines is that the recommendation for some of these medications is independent of A1C. So even if patient is at A1C goal or below, you can still use some of these medications for benefit to target things like ASCVD risk, heart failure, and CKD. So you might not get much benefit with some of these medications for A1C reduction if a person has already a pretty good A1C, but they can still benefit from these medications in other ways. And that sentiment is sort of echoed here in the American Association of Clinical Endocrinology guidelines, where they also state that independent of glycemic control, if they have highest ASCVD risk or if they have chronic kidney disease, they recommend SGLT2 inhibitors or GLP-1 receptor agonists. And again, that might not be so much for A1C reduction, but more for the preventing progression of other diseases like CKD or ASCVD. One thing I like to think about when I'm trying to pick treatments for a patient for diabetes is this ominous octet. So some of you might be familiar with this. Generally, when it comes to hyperglycemia, we think of 8 different pathologies that contribute to hyperglycemia. So keeping these in mind as we pick therapies and sort of add on to our medical regimens can help us narrow down what we're going to select. So things that can lead to hyperglycemia include decreased insulin secretion, increased glucagon secretion from the pancreas, increased hepatic glucose production, neurotransmitter dysfunction, decreased glucose uptake in the periphery, like the muscles, increased glucose resorption in the kidney, and increased lipolysis from adipose tissue. So if we think of these 8 different things that contribute to hyperglycemia, it can help us select medications that we use to add on to therapy based on what patients are currently on and where we might see the most benefit. Fortunately, with diabetes, we have a lot of options when it comes to pharmacological treatment. We'll try to get to most of these, certainly talk about the most popular ones, but there are a lot of options in diabetes treatment, so we are pretty fortunate. And you'll notice at the bottom here on the left, there is a new class of medications. Technically, this is a new class, glucose-dependent insulinotropic peptide, or GIP receptor agonist. So there's a new medication on the market called Mounjaro, which we will talk a little bit about in this presentation later on, but just keep in mind that that is a new class of medication. Some of these medications are older and have fallen out of favor, and you might never see in practice used to treat diabetes, but all of these on here do have an FDA-approved indication for diabetes. So let's circle back to our patient case here. She's already on metformin when she presents to us, so she doesn't have to be on metformin first line anymore, but this patient is, so that's a good first start. And then we'll sort of talk about how we can optimize her treatment going forward here. So she's already on metformin, so we'll start with our discussion there. This class of medication is known as bigranides. It's sort of been the workhorse for diabetes treatment for a long time. It's an older medication, it works well, a lot of providers are familiar with it. It has pretty significant A1C reduction, as you'll see, compared to some of the other classes, about 1.5%. So that is a good reduction in A1C for a lot of patients. It works primarily by decreasing the amount of glucose produced by the liver. Adverse effects associated with metformin can be GI upset. Usually that's on onset of medication and does self-resolve over time. If you sort of titrate up doses with starting at maybe 500 milligrams with dinner for a week and then going up to 500 milligrams twice a day for a week, 500 in the morning and 1500 in the evening, and then hopefully getting up to 2 grams daily, that can sort of help sort of titrate a person as they get used to the medication and reduce some of those GI side effects. Also, switching to the extended release of the medication can help too. Other adverse effects to keep in mind with this medication are lactic acidosis and macrocytic anemia. So metformin itself does not cause AKIs, but in the setting of AKI, this risk of lactic acidosis goes up. So that's where we do hold this medication if they're going to be receiving things like contrast that can increase the risk of AKI and then possibly lead to lactic acidosis. And with that, renal function is a little bit odd for metformin. In patients that have an eGFR of 30 to 45, you can stay on metformin, but the max dose is 1,000 milligrams daily, and it's typically not recommended to start a patient on metformin if they're in this range. So if they're already on it, it's okay to stay on it, just to make sure the dose is 1,000 milligrams daily maximum. But if they do drop below the 30 milliliters per minute per meter squared level, that's where use is contraindicated. So when we're thinking back to our ominous octet with metformin, it's primarily going to be working for us by working in this pathway where it'll help to decrease the amount of glucose produced by the liver and hopefully reduce the amount of hyperglycemia. So going forward here, back to our patient case, when trying to decide if this patient's at goal or not, her A1C is 8.9, so not at goal. The ADA and ACE kind of do differ in the recommendations. ADA says less than 7%, ACE says less than 6.5%. But again, those A1C goals are going to be very individualized for patients. Here we have a relatively young woman, not a very extensive medical history, so she's relatively healthy compared to some of the patients we see, not at a high risk of comorbidity. So we can get pretty aggressive with our A1C treatment if we'd like. So certainly 8.9 is not ideal for her. And if we go back to our guidelines, this ACE guideline I kind of like, because if we look for their recommendations for monotherapy and dual therapy, they put them in hierarchical order. So these are what they recommend in order top down. And the green bars underneath each medication class is the strength of recommendation. So you can see here for monotherapy or for dual therapy, right after metformin, they're recommending GLPs and SGLT2s as their next classes of medications. And these green bars are completely full. So it's a very strong recommendation for them from ACE. We come back to our patient here trying to decide which medication to go forward with. We can see we have an EGR of 56. So technically this patient has CKD. And as we saw with both the ACE and ADA guidelines, they do recommend for patients with chronic kidney disease to be on SGLT2 inhibitors. And again, that is independent of A1C control. So even if she had an A1C that we were happy with, she still may benefit from being on SGLT2 inhibitors to help prevent that progression of chronic kidney disease. Sorry, just get back to where we were here. So going forward with SGLT2 inhibitors, we do have 4 of them on the market. Ertugliflozin, you might not see too much. It's Stelgotro. It was the last one to the market, not very commonly used, but we do have Invokana, Farxiga, and Jardiance, which most people are probably pretty familiar with these days. They inhibit the glucose reabsorption in the proximal tubule of the kidney. One possible complication of this medication is euglycemic DKA. So patients end up in DKA. Usually there's something that happens to cause this, either an illness or a patient gets dehydrated or something that predisposes them to getting DKA. So hydration is really important with these medications. This risk of DKA is why it is not approved for the use in type 1 diabetics. But some providers will still use these medications to treat type 1 diabetics. You just have to really counsel them on making sure they stay hydrated. And it's recommended that you provide them with urine ketone test strips so they can test their urine for ketones just to make sure if they do have any signs of DKA that they're able to test and make sure they get medical attention if needed. So the most common agents you'll see again are the Jardiance, Farxiga, and Invokana. There is also another medication. It's an SGLT1 and 2 inhibitor. It's only approved in Europe. It's called Zynquista, or Zynquista. Sotagliflozin is the generic name for that one. It's not approved in the US, but it is approved for type 1 diabetics in Europe. And the SGLT1 transporter is located in the gut. So the thought there was that we could also inhibit sugar reabsorption in the gut as well as in the kidney and sort of get more bang for our buck here. But because of the high risk of DKA, that was not approved in the US. Benefits with these medications here. So again, they go beyond A1C reduction, which is pretty good, 0.5 to 1%, but they've also been shown to reduce the risk of cardiovascular disease, prevent hospitalizations for heart failure in patients with now both preserved and reduced ejection fractions, and reduce the risk of chronic kidney disease progression. So a lot of added benefit to using these medications in a lot of different patients. The next medication class that I want to talk about here is also highly ranked on a lot of the guidelines, are the GLP-1 receptor agonist. So here we have exenatide, liraglutide, or Victoza, dulaglutide, or Trulicity, semaglutide, which comes in both the injectable form as Ozempic and the oral form as Rybelsus. It also comes as a medication for weight loss known as Wegovy. And then there's lixazentide, which is no longer available as a standalone agent, but it is included in a combination product with Glargine called Soliqua. So these medications, we do get, again, pretty significant A1C reduction, generally around 0.8 to 2%. So pretty good improvement in A1C control there. And they work by, they're synthetic analogs of GLP. So they restore the incretin effect in diabetic patients. So the incretin effect is something that we'll talk a little bit more when we talk about Mounjaro, but it's something that is tends to be dysfunctional in diabetic patients, and giving these supraphysiological levels of GLP receptor agonists can really benefit patients in terms of A1C reduction, weight loss, and cardiovascular risk reduction. So some of the possible adverse effects here are GI upset. Usually, again, that's with onset of medication or with dose titrations. It does usually tend to dissipate in about 3 to 4 weeks with patients. So try to counsel them on sticking it out and seeing if those symptoms do resolve and making sure that they stay hydrated. So you might see And some of the package inserts, AKI may be at risk with this medication. Really, that's just associated with the dehydration that they get from nausea and vomiting. You can also see injection site reactions, and there's some caution in pancreatitis. So if you have a patient who historically, maybe 10 years ago, had pancreatitis, and it can be associated to maybe alcohol use or poor diet, and that's no longer an issue now, it is still safe to use these medications in those kinds of situations. It's where they have sort of chronic history of pancreatitis or acute pancreatitis where you want to avoid these medications. Also, they have a box warning for use in patients with medullary thyroid cancer. So this is a rare type of cancer. The risk is not known in humans, but this comes from studying these medications in rodent models. So if you have a history of or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2, it is advised to stay away from these medications. They are safe to use in patients with histories of other thyroid cancers, so things like papillary thyroid cancer or follicular thyroid cancer. With Ozempic specifically, there is a warning for those with progressive retinopathy. And the thought behind that is the sudden rapid reduction in serum glucose levels causes an osmotic difference that damages the eye. So because we are dropping the sugar so fast and so rapidly in these patients, it's thought that is what leads to the worsening of diabetic retinopathy in patients. So if they have a history of that, using an agent that maybe has less A1C reduction, such as Trulicity or Victoza, might be a preferred option versus something like Ozempic. And just comparing these two classes here, because I really do think that these are going to be the workhorses of diabetes as we go forward. So traditionally it's been metformin, and now I think these medications will be right up there with it when we're talking about first line options of treatment. So we have our SGLT2 inhibitors, which have good A1C reduction. They reduce the risk of 3-point MACE, so death from cardiovascular cause, non-fatal stroke, and non-fatal MI. So both Jardiance and Invokana did show that in their cardiovascular outcome trials. Farxiga or dapagliflozin did not. It was not significant, but it did reduce the risk of hospitalizations for heart failure. Overall, there's been enough meta-analysis now to suggest that the reduction in cardiovascular risk is a class effect with these medications. But when Farxiga did their cardiovascular outcome trial, it was a non-significant reduction in 3-point MACE. So that's why I just have empagliflozin and canagliflozin listed there. They all have shown less worsening of nephropathy. Their trials all used a little bit different criteria in terms of measuring renal outcomes, but overall they were all significant in terms of reducing the progression of CKD. You do get a pretty significant weight loss with SGLT2 inhibitors. It's not as much as you think it would be based on the amount of glucose that is being excreted in the urine, because patients' appetite can actually tend to increase with these medications because they are urinating out so much glucose. So you don't get as much weight loss as you would think, but that provides an opportunity to pair it with a GLP-1 that has appetite suppressive properties and really get some bang for your buck in terms of weight loss. So with the GLPs, also robust A1C reduction in 3-point MACE. In terms of heart failure outcomes, they were non-inferior to placebo, but no benefit. But they do also have some evidence to suggest that they are beneficial in terms of progression of CKD, and there are currently studies ongoing for this too. So we may have more data about that coming forward. And again, a lot of weight reduction with this medication. And then perhaps the most important thing with most of these medication classes is that there's no hypoglycemia risk with these agents alone. So GLPs do increase the amount of insulin that is secreted from the pancreas, but it does it in a glucose-dependent manner, so only in the presence of hyperglycemia. If your blood sugar drops, GLPs will not stimulate further production of insulin, so you can't get hypoglycemic. Where the risk of hypoglycemia does come into play is starting these agents in patients that are also on insulin. So you're going to be decreasing their insulin requirements. So that can increase the risk of hypoglycemia, but that's from the insulin, not from these medications. When it comes to picking which one of these medications, in a lot of patients, it's going to be a toss-up or based on patient-specific factors, whether they'd rather take a weekly injection or a daily pill. As long as they are usually on one of these medications, that is what's recommended. And then when it comes to adding on another medication, you would just add the other class. And there is evidence to suggest that using these medications in combination with each other is both safe and very effective. You get additive benefits in a lot of outcomes. So one of those trials was the SUSTAIN 9 trial, where they they studied Ozempic with add-on to SGLT2 therapy, and you really got a robust A1C reduction and a lot of weight loss, and the adverse effects were consistent with using the agents as individuals as well. So not an increased risk when you use them together. So you can get aggressive and start both of these medications at the same time if you think it's appropriate for some patients. Coming back to our Agonist Octet now, when we think about these medication classes in our patients. So she's already on metformin, so we're targeting the liver there with our treatment. If we started her on an SGLT2 inhibitor, then we're targeting the glucose reabsorption with those medications. And then with the GLP-1s, you see really significant effect because it works, as I mentioned, to increase the insulin secretion from the beta cells in the pancreas. It also decreases glucagon secretion from the alpha cells in the pancreas. And then these medications also increase the incretin effect and increase satiety in patients. So 4 different mechanisms that really help improve hyperglycemia or lower the hyperglycemia. So now in patients that are on these 3 medications, we're targeting 6 out of these 8 mechanisms that lead to hyperglycemia, and we can usually get pretty good control, as well as have added benefits in terms of reducing some risk of other complications. So back in our patient here, she reports now 6 months after that initial visit. So you see with her medications here now, we had started her on Jardiance or empagliflozin 10, and we got her on Trulicity 1.5 milligrams weekly. So now this is 6 months after we initiated those medications, and she reports with these labs an A1C of 7.8. So getting better, but maybe still not quite at goal. LDL of 89, triglycerides of 207. Her eGFR is 49. So you notice that dropped a little bit from the original 56. And that can be expected from starting SGLT2 inhibitors, similar to when you start ACE inhibitors. So the SGLT2 inhibitors, they don't just inhibit the reabsorption of glucose, they also inhibit the reabsorption of sodium. And when that sodium reaches the macula densa and the nephron and the juxtalar glomerular apparatus, it'll slow down GFR, which can lead to a little bit of a serum creatinine bump and cause this transient decrease in eGFR. So if that's less than 30%, similar to when you start an ACE, it's safe to continue this medication. It is transient. There's data to show that if you stop the medication, that eGFR does rebound back up. So don't be concerned if you start an SGLT2 inhibitor and you notice a little bit of an increase in serum creatinine. That is normal. It's not a sign of kidney damage. Overall, these medications on the long term do help slow the reduction in eGFR. So it is beneficial in terms of kidney production or kidney disease progression beyond these SGLT2 inhibitors. And then when it comes to picking GLP-1s, I'll just talk about this quickly here. This patient was started on Trulicity. She does not have a history of coronary artery disease, so she's considered primary prevention still. So Trulicity is the only GLP-1 receptor agonist to be approved by the FDA for reduction of risk as primary prevention for reducing the risk of ASCVD. And what that comes from mostly is when they did the REWIND trial for their cardiovascular outcomes, it had almost 70% of patients that were considered primary prevention. So the FDA was able to grant them approval for that indication. The other agents like Victoza and Ozempic, they had less than 20 and less than 30% respectively primary prevention patients. So that was mostly secondary prevention trials. So the FDA granted them approval for reducing the risk in secondary ASCVD, but not for primary. So it's not that Ozempic and Victoza don't work to reduce the risk of ASCVD as primary prevention. It's just the data wasn't strong enough to grant them that indication. So that's why Trulicity is currently the only agent on market with enough data to show that it does reduce the risk of heart attack, stroke, or cardiovascular death in diabetic patients without a prior history. And then talking about options at this point for this patient going forward. So we do have quite a few options. Now Trulicity does come in higher doses of 3 milligrams or 4.5 milligrams. So there is an option of increasing the dose of Trulicity to get further A1C reduction. You don't really see a lot of benefit when doing that. The trials, when they were looking at the higher doses of Trulicity, it was only about a 0.1 to 0.2% A1C reduction when going up to top dose of 4.5 and about an additional 2 pounds of weight loss. So some patients may respond better than that, but on average, it's not really a whole lot of impact that we get from increasing the dose of Trulicity. But if they're already on it and they already tolerate it, I do think it's reasonable to try to increase the dose and top it out before you consider switching to different agents that might have more of an effect. And then if we were thinking about adding on other medications, there are a few other classes that we do still have options. One that I think is sort of underutilized are the TZDs. So the only agent now on the market for that is Actos or pioglitazone. So Avandia or rosiglitazone was removed from the market for possible increased risk of heart attack. So TZD as a class have had a bit of a bad name in history because the first one to market was removed for hepatic toxicity, and then Avandia was removed also. But that does leave us with pioglitazone, which is a good agent. We get good A1C reduction with 1.5%. It works to increase insulin sensitivity in the periphery, so we'll talk about the benefits of that soon. It does, however, have the negative effects of weight gain and edema. So as soon as a lot of patients hear possible weight gain, they kind of steer away from these medications. But that weight gain is a lot to do with fluid, which can be managed with things like Lasix or the adipose tissue that is added on. It's shown to be more subcutaneous fat as opposed to visceral fat, which it's really the visceral fat that leads to an increased risk of cardiovascular disease and poor outcomes. Subcutaneous fat is thought to be less negative than the visceral fat. So may not be as big of a concern if patients put on a little bit of weight because it's usually associated with subcutaneous fat. Where there is an increased risk in patients is for heart failure exacerbations with these medications. And again, that is a lot due to the fluid retention that's seen. You can also see atypical bone fractures or a possible increase of bladder cancer, which is associated with possibly with Actos. The data on it's a little bit unclear right now, but keep that in mind. You may want to stay away from it with patients that are at risk for bladder cancer. These medications, their mechanism is they're PPAR gamma agonists, so they do have some cross reactivity with the PPAR alpha receptors, which are how fibrates work for lowering triglycerides. So in patients where maybe their A1C is okay, but their triglycerides are more of a concern that you want to help reduce, you can have some benefit with using TZDs. It can lower the triglycerides about 15% also. So that can be another area where patients might benefit from this class of medication. And like I said, with the mechanism of action, if we think about our patient that was on 3 medications that targeted the first 6 out of the 8 in this ominous octet, and then if we add TZDs on it, they work in both the adipose tissue and muscle tissue. So now with these medications, we are targeting all 8 out of the 8 mechanisms that lead to hyperglycemia. So really, we can expect to have a lot of hopefully good control in patients with using this combination of medications. The new medication that I want to talk about is this new class of medications. Mounjaro or tirzepatide is the one that fits in here. So first, just a quick review of the incretin effect. So the incretin effect is when you ingest nutrients, specifically glucose, you really have a strong increase in the amount of insulin that is secreted as a result from that glucose being absorbed from the gut. If you just give glucose IV, you don't get that same increase in insulin secretion. So these hormones, GIP or glucose-dependent insulinotropic peptide and GLP are what are responsible for that significant increase in insulin secretion and overall increased glycemic control in the postprandial setting. So GIP formerly used to be known as gastric inhibitory peptides. If you see that, it's referring to the same thing, just the preferred name now is glucose-dependent insulinotropic peptide. Like I said, this agent Mounjaro, so you can see here the A1C reduction. Previously, we had nothing over 2%. This one is 2 to 2.5%. So really significant A1C reduction. It is a single molecule that stimulates both the GIP and GLP receptor. That's a little bit different from some other agents that are being studied where there is a GIP receptor agonist in combination with a GLP receptor agonist. This medication, Mounjaro, is just one single molecule that does both. So it's pretty interesting medication. In terms of side effects, they are very similar to what you would see with the GLPs. It's the same box warnings for medullary thyroid cancer, same risk for GI upset. Again, that's usually with dose increases or when you start the medication. And same risk with pancreatitis and with retinopathy because we do have a very significant A1C reduction, again, similar to the Ozempic here with these patients. You can see here with this medication, it comes in a lot of different doses actually. So the ones that were studied were 5, 10, and 15, but it's available in 5, 7.5, 10, 12.5, and 15 milligrams. So a lot of options for our patients. I do think a lot of patients will probably be okay at the 5 milligram dose and then hanging out there for a while, but it does offer a lot of room to titrate up if you do need further A1C control or further weight loss. You can see at the top dose here, the tirzepatide 15 milligrams. The percent of participants achieving A1C less than 5.7, so even below that pre-diabetes range, was almost 51%. So that's a pretty significant A1C reduction, and less than 7 at 92.2%. So pretty excited about this medication. Hopefully we can start getting better coverage for it in the area so that we can get more patients on it. But looks like this is going to be sort of the next big wave in diabetes management. With adverse effects, like I said, they're similar to the GLPs. The issues is it's a longer dose titration schedule, so those symptoms may be prolonged just because you're increasing the dose further over a longer period of time. So you can see here compared to semaglutide 1 milligram, the rates aren't really any different. It's just that they're longer because you have a longer dose titration schedule than you do with Ozempic. Now I'm going to talk about some other medications that are maybe less preferred, but you may see or do have some role in therapy still. The sulfonylureas, one of our older medications for diabetes, kind of fallen out of favor because they're what we refer to as dumb secretagogues. So as opposed to a smart secretagogue like the GLPs, where they secrete insulin when it's needed. These medications, these sulfonylureas, will secrete insulin even when it's not needed. And that's what leads to the increased risk of hypoglycemia. So even if there's no blood sugar around, they're going to increase the amount of insulin that's being secreted. And that's not good for a lot of patients, particularly those with chronic kidney disease or those that are elderly. It is also, because it stimulates so much insulin secretion, it can cause weight gain because insulin is anabolic. So a lot of these patients will experience weight gain with these medications. They are cheap though, so that is kind of why we do still see them in practice, and you'll see where they fall in the guidelines here in a second. But they can also lead to beta cell burnout if they're used for a long time. So if patients are on these for extended periods of time, they can actually burn out the beta cells quicker and cause a further progression of disease. You can see here from the ADA guidelines where the sulfonylureas fit into their recommendations is really only if cost and access is the main consideration for patients. So otherwise, it should not necessarily be avoided, but maybe not first line or even second line options for patients, just because nowadays we have so many other agents that have so much more added benefit and do not have the hypoglycemic risk. Another class of medications that really aren't too popular anymore are the DPP-4 inhibitors. So the ones you may be familiar with are the sitagliptin Januvia or linagliptin Tradjenta. So these came out slightly before the GLP-1s. They work on a similar pathway where they prevent the degradation of GLP and GIP. So you're getting physiological levels, but over an extended period of time. So you have an increased exposure to the GLP and GIP, whereas giving the GLP and GIP receptor agonist gives a super physiological response to those medications. So just a much more robust response when you're giving the injectables as opposed to these DPP-4s. They do have some GI upset associated with them. Generally, they're overall pretty well tolerated though. Could increase the risk of pancreatitis. So you would not use these in combination with GLPs just because they work on the same pathway. So there'd be no benefit and you possibly just increasing the risk of pancreatitis. We'll talk a little bit about the heart failure risk in a second here, but I like to just point out that if you're going to keep one of these sort of in your back pocket to use, linagliptin or Tradjenta, it only comes in 5 milligram dose, so there's no renal or hepatic dose adjustments needed. So that keeps it pretty easy. It's 5 milligrams and always going to be 5 milligrams. So that's kind of just a little thing to make it easy if you're going to keep one DPP-4. So when I mentioned the risk of heart failure, this is where that possible increased risk comes from. So cardiovascular outcome trials for DPP-4s, the first one you had was for saxagliptin or the SAVOR trial. And then they did the alogliptin, sitagliptin, and linagliptin respectively. None of these medications showed an increased risk of cardiovascular events, but they also had no benefit. So In terms of 3-point MACE, no increased risk, but also no benefit. So that was an okay find. But then when they looked at the risk for heart failure hospitalizations, so the first trial for saxagliptin showed a statistically significant increased risk of heart failure hospitalizations. And then the next trial to come out and examine showed a numerically higher, but it wasn't statistically significant increased risk of heart failure hospitalizations. So that's where the possible risk of heart failure hospitalizations with these medications sort of the thought sort of comes from. But the next trials that came out, both the TICOS for sitagliptin and the Carmelina for linagliptin, showed no increased risk of hospitalizations for heart failure. So keep that in mind. Generally, these medications are sort of more of a niche now in patients that either refuse to give injections or haven't tolerated GLPs. They just prefer a pill for some reason. Maybe these DPP-4s are an options for them, but with the ones that are on the market now, the sitagliptin and linagliptin, there's been meta-analysis done to show that there is most likely no increased risk for heart failure, but again, no cardiovascular risk reduction either. These other medications I just want to talk about really quick, just because they are possible options. You probably will not see them for use in diabetes, but they do have FDA indications. So you have your alpha glucosidase inhibitors, your bile acid sequestrants, which may be used for some patients if you also want a little bit of LDL reduction, but they're not really that great to take. Dopamine agonists, so there is one on the market, Cycloset, which is approved for diabetes treatment also. Amylin mimetics is something that probably haven't seen too much because the GLPs sort of stole its thunder. Right when it came out, the GLPs were right on its tail, and it was dosed 3 times daily. So when the GLPs came out with their daily or weekly formulations, people kind of just never gave amylin a chance. But they are studying it currently in long-acting forms. So it may make a little bit of a comeback in a once-weekly injection. That's sort of in the pipeline up and coming. Then we have meglitinides, which also have sort of fallen out of favor. They also are what we call dumb secretagogues and can cause hypoglycemia. So these medications that are options, maybe if you're trying to treat something else and want a little bit of A1C reduction, you can have the added benefit, but generally not something you're going to use to treat patients for type 2 diabetes. I included this slide just quickly as an FYI of the different brands, generic names, and the strengths that they have come in. This slide's here, really not so much to talk about insulin, just for time's sake, but more to show that when you are considering injectable therapy, the ADA does recommend GLPs as first-line injectables. So when it comes to start thinking about injectable therapy for patients, before you get to insulin, you should be considering if a GLP is more appropriate or GLP in addition to insulin. So their recommendations are, if injectable therapy is consider GLP-1. And then when it comes to titrating up doses, rather than titrate up doses, are they already on a GLP? If not, you should start one probably. Now I just wanted to spend some time sort of talking about non-glucose lowering diabetes medications. So these are drugs that aren't really used to lower A1C, so they're not technically diabetes medications, but we do commonly see them in patients with diabetes, and they do have benefit for patients in this population. So here's sort of our pillars of diabetes treatment. This is kind of similar to what we see with the pillars of heart failure disease. So we have glycemic management, which we talked a lot about. And then on the far right, we have agents with cardiovascular and kidney benefit, which we talked a lot about with the SGLT2s and the GLP-1s. So we'll talk a little bit more about that, and then a little bit about the agents that we use for blood pressure and lipid management in the diabetic population also. So RAS system, probably a lot of you are pretty familiar with the ACE and ARBs in diabetic patients. So these are to reduce the progression of chronic kidney disease. So they're indicated for patients with diabetes that have either a history of hypertension, so it can be controlled hypertension, it still meets criteria, or type 2 diabetes and albuminuria, so a urine albumin creatinine ratio greater than 30. If they have either of those, they're indicated to be on RAS inhibition. So either an ACE or an ARB, there's not really preference given to one class over the other. But again, here you don't discontinue these medications if serum creatinine increases a little bit. So similar to what we saw with those SGLT2s, it is expected that the serum creatinine will go up a little bit. If it goes up too much, like in that 30 to 50% range with the ACE and ARBs, you can half the dose and continue them on the medication. If it increases more than 50%, it is recommended to discontinue these agents. Another newer option here on the market is this finerenone. It's a non-steroidal mineralocorticoid receptor antagonist. So it's similar to spironolactone, but you don't get the off-target effects like gynecomastia that you would with spironolactone. So it was studied in patients with diabetic kidney disease. And now it's indicated for those that have an increased risk of cardiovascular disease or risk of CKD production. The thing is, when they studied these medications, it was before the SGLT2s were really popular. So a very small percentage of patients in these trials were on SGLT2 inhibitors. So our role in combination with SGLT2 isn't really well understood. They are currently doing trials to get a better idea of that. But where this sort of fits into therapy these days at this point is more so for those that don't tolerate SGLT2 inhibitors, but you want them to have some cardiovascular risk reduction or help prevent the chronic kidney disease progression. So if they don't tolerate SGLT2s, which we know do those very well, maybe finerenone is an option. And then hopefully soon we have more data about using the combination SGLT2s and finerenone together. Statins and diabetes go hand in hand. So type 2 diabetics who are aged 40 to 75, or if they're younger, 20 to 39 with other risk factors, even in primary prevention, statins are recommended. And then it's recommended for all patients for secondary prevention that have diabetes. And generally, it does tend to be a little bit easier if you start patients, I think at least, on high intensity statins off the bat. And then if they don't tolerate it, step down rather than starting with a moderate intensity. I think when we start with moderate intensity, patients just get on that and then they're on it for the rest of their lives. And then it's never really increased to a high intensity statin, or when you try to increase the dose, that's when all of a sudden the leg and muscle pains start to show up. So in general, if you start patients on high intensity statins and they tolerate it, it's easier to go that route than it is to start at moderate and titrate them up. Another sort of diabetes, but not really diabetes medication is Vascepa. So this is Icosapent Ethyl. It is a purified EPA form of omega-3. So it doesn't have any of the DHA that comes in like most of our fish oils or our Lovasa, which are EPA, DHA combinations. So this is strictly EPA, and it was studied in the REDUCE-IT trial with type 2 diabetes who had ASCVD risk and controlled LDLs with triglycerides greater than 135. And this medication showed a reduction in cardiovascular risk. So not only did it reduce the component of these 5 points, so they use a 5-point MACE in this trial, so death from cardiovascular disease, non-fatal MI, non-fatal stroke, coronary artery revascularization, and hospitalization for angina. It also reduced the risk of each individual component of the component outcome. So it statistically significantly reduced the risk of each of 5 of these components individually. So that was a pretty significant trial. So in our patients where, we have our A1C controlled, we've optimized our lipid control in terms of LDL management, we should really thinking about, is there still some further A1C or ASCVD reduction we can do by looking at their triglycerides. And if the triglycerides are elevated, it is recommended that they be on Vascepa. Circling back to our patient now, at the last visit that we saw that we wanted a little bit more A1C reduction. So we started her on the Actos or the pioglitazone 30 milligrams. And now she's coming back to us again, and we see our A1C is at 6.7. So if our goal for her was 7, she's below that, so that's great. LDL is 78. So ACE, or the American Association of Clinical Endocrinologists, actually recommends the threshold of less than 70 for patients with type 2 diabetes and risk factors. So she's okay with a 78, but it's not below the threshold recommended. So there is some opportunity for improvement there. And there's a few things we can do. We can increase the atorvastatin to 80 milligrams and top that dose out, or we could add Zetia. She has primary prevention, so it might be a little difficult to get a PCSK9 inhibitor approved in this patient, but if she was secondary prevention, that would definitely be something we should be considering. And then we see her triglycerides here of 187. So that is over 135. So she does meet the criteria with type 2 diabetes, ASCVD risk factors, and triglycerides over 135. Some insurance companies will use 150 as a cutoff. The trial was 135. The FDA says 150. So there's a little bit of a gray zone there, but certainly at 187, she meets the criteria for Vascepa as well to further reduce her risk of ASCVD. And I think that just sort of highlights that in these patients, they're here for diabetes, and we've targeted the A1C, we've gotten good A1C control, We've done our lipid management, but there's seems to always be more we can do. And we're just really trying to avoid stagnation and keep that clinical inertia going and really lowering the risk of possible comorbidities that can be seen with these patients and optimizing their therapy as at each visit as we go. So thank you very much. That's all I had for you guys today. Are there any questions? Check the chat here.
Thank you so much, Dr. Quinn. And I so appreciate you including the case as well inside of your presentation. It always helps put what you're presenting in perspective too. So we really appreciate when presenters do that. Thank you. Any questions or comments? I know Fraz was having audio or microphone issues, but I'm glad he was able to hear it. Tim, Vida, I see you guys are connected to audio as well, which I'm glad about. But any questions you all have, you're welcome to unmute and ask away. Questions or comments? Giving it the long echo pause here. Fraz, I see you chatted in. Thank you. I'll give it a little moment. He might be typing, so we'll wait and see. Very informative lecture. I look forward to rereading the presentation. Thank you. That's nice of you, Fraz. Thank you.
If anyone has any questions, you can feel free to reach out. My contact information should be included on the slide there, so I'd be happy to answer any questions.
Yes, absolutely. All right. And if any of you have questions, you can email Elizabeth or myself, and we'll be sure to pass it along to you, Dr. Quinn. All right. Well, thank you again so much. We always appreciate your time and sharing your expertise with us.
Thanks for having me.
All right. The only announcement that I have is the next session is on September 28th, and Dr. Jennifer Turner will be presenting on goiter management. So we look forward to seeing you all next time. Thanks, everyone.
Bye. Thank you.
Bye.